everyone to the November 8th meeting of the Joint Conference Committee for Laguna Honda. Let's see, Mark, I'm gonna ask you, or call us to order, do the roll, and then ask you to call out the agenda items if you don't mind.
Sure.
Yeah.
I'll start with you, Commissioner Guillermo.
Present.
Commissioner Green. I didn't hear you. I'm sorry, Commissioner. All of you were muted when we came back into open.
Present.
Thank you. And Commissioner Chow.
Present.
Great. I will read the land acknowledgement before we move forward. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, the approval of the October 11th meeting minutes.
Okay, thank you, Mark. May I have a motion to approve the minutes?
So moved.
Second.
And there is public comment, so and I'll call it out again. Folks on the line, we're on item 2, the approval of the October 11th minutes. If you'd like to make comment on this, you can press *3 to do so now, and then you'll have 3 minutes to make comment. I'm going to mute you, caller. Please let us know that you're there.
Yes, Mr. Morwitz, this is Patrick Monette Shaw. I am now recovering from my surgery to remove the squamous cell carcinoma. I'm at Jewish Home and am scheduled to be discharged to my home on Sunday, at which point I really look forward to submitting written public testimony. I do want to comment on this agenda item that the commissioners should accept the minutes under consideration. And I want to warn you that when I start public comment, Mr. Morwitz, I am referring to previous articles by Dr. Derek Kerr and by myself, citing information from long-term care ombudsman Benson Nadell, and it's going to refer obliquely to the Laguna Honda closure plan, but this is First Amendment free speech about my articles and Dr. Derek Kerr's articles in the Westside Observer. So please, sir, do not cut me off. Thank you.
All right, that's the only public comment. Commissioners, any comments or questions from you about the minutes?
Okay, I don't see any hands up at this point, so I think you can.
Roll call vote?
Yeah.
I'll start with you, Commissioner Guillermo.
Yes.
Commissioner Green.
Yes.
And Commissioner Chow.
Yes.
All right, the minutes are approved. Thank you so much. Item 3 is general public comment. And folks on the line, this is for topics that are not listed on the agenda. So again, general public comment, you can press *3 to raise your hand. All right, I see one hand. Caller, please let us know that you're there.
It is. It's Patrick Monette Shaw. I want to apologize for my slurred speech, which is caused by the swelling in my face, dragging my facial muscles and mouth downward. Put up with my slurring, please. I'm not drunk. In surgical recovery. Back in 2004, the Health Commission viewed Laguna Honda as a quote-unquote silo. And at that time, long-term care ombudsman Benson Nadell warned you commissioners that Laguna Honda is, in fact, a, quote, regulatory silo, end quote, for good reason. Laguna Honda is a silo and has always been a silo because it has to follow CMS regulations regarding skilled nursing facilities. You ignored that back in 2004 and you allowed SFGH management like Mr. Roland Pickens to come over to Laguna Honda and pretend that they were following California Title II regulations regarding acute care hospitals. I have testified Laguna Honda has 5 acute care beds that are rarely used, but Laguna Honda is a SNF, which means you have to follow CMS SNF regulations, which you failed to do. Notably, about the time you claimed Laguna Honda should not be a silo, you canned Mr. Larry Funk, who had been a licensed nursing home administrator. Now, your consultants are stepping into a temporary role of using consultant staff to be nursing home administrators, and in fact, you have a long-range plan to hire both a nursing home administrator and an assistant nursing home administrator. This Health Commission needs to mandate that Laguna Honda start advertising and recruiting and filling the nursing home and assistant nursing home administrators ASAP. Otherwise, as you get into the settlement agreement, those administrators.
That's all. Your time is up. Thank you very much for your comments. All right, commissioners, we can move on to the executive team report, item 4.
Okay, Mr. Pickens.
Yes. Good afternoon, commissioners. Good afternoon, members of the public. Thank you for this opportunity to present the Laguna Honda Hospital Executive Team report today. I'll start off and we'll conclude, and members of the executive team are here on the call and will be happy to try and answer any questions that you may have. Next slide. So as you all know, Laguna Honda is the largest publicly run skilled nursing facility in the country. We've been around for more than 150 years and provide a plethora of services, a vast array, more so than any other nursing facility in the Bay Area or the country. We care for a highly complex patient population representing conditions such as stroke, traumatic brain injury, degenerative diseases, and such as multiple sclerosis. We have an extensive rehabilitative service, including physical, occupational, and speech and language pathology services and audiology. And we are particularly proud of our specialized care units, including monolingual Spanish and Chinese units, along with the palliative care unit and the only Bay Area AIDS, HIV, memory care unit. Next slide. Again, you will recall back in April of this year, in follow-up to 2 self-reported cases of non-fatal overdoses of Laguna Honda residents, we underwent a series of monitoring surveys and compliance surveys by California Department of Public Health on behalf of the Federal Centers for Medicaid and Medicare Services. That unfortunately resulted in Laguna being found to be out of substantial compliance with all of the required CMS regulations. At that point in April of last year, CMS terminated Laguna's participation agreement that funded and continues that CMS funding funds the majority of the resident care provided at Laguna to the tune of $550,000 a day, or more than $200 million annually. Next slide. Since that decertification in April, the staff at Laguna, along with others across the Department of Public Health and San Francisco Health Network, have been working hard to put Laguna on a path towards regaining CMS certification. That path included the addition of 2 expert consultant groups, Health Services Advisory Group and Health Management Associates. Both groups have been on the ground at Laguna since the middle of May and have been guiding all of our efforts along with the staff and leadership towards recertification. Next slide. You will recall that recently, a little over a month ago, that in response to the CMS decertification, the city attorney filed a lawsuit on behalf of Laguna against CDPH and CMS. We were happy to learn that that lawsuit, there was a settlement agreement reached by the city attorney on behalf of Laguna Honda. And that settlement agreement did a couple of things. First of all, that tentative settlement agreement at that point extended payments to Laguna up until and at least through November 13th of 2023. So it allowed for a path of continued funding, which had been one of our asks from the very beginning. In addition, that settlement agreement also extended the pause in transfers and discharges of residents out of Laguna, which is something else that we had originally asked for, really the ability to not have to move patients. The settlement agreement is making its way through the appropriate approvals through the Board of Supervisors, the Mayor's Office, and then back to CMS. And we await to hear the final conclusion of that approval process. Next slide. In addition to the settlement agreement, one of the provisions of moving towards recertification in our agreement with CMS is that Laguna Honda needed to identify and have CMS approve a quality improvement expert, or a QIE as CMS refers to it, to complete a root cause analysis. And the purpose of that root cause analysis is to help identify causal factors that may have led to the circumstances that resulted in Laguna being deemed decertified. Luckily for us, Health Services Advisory Group, who we had already secured their services in May, was approved by CMS about a month ago to be that quality improvement expert. So again, we're grateful that we've got a consultant who actually has been on the ground and knows the organization well. And they have already began to compile their root cause analysis, and they will be submitting that root cause analysis to CMS for CMS's review and approval. And once approved by CMS, they will then turn over those results to Laguna Honda, and then Laguna Honda will work in conjunction with Health Services Advisory Group to complete an action plan. That action plan will address all of the causal factors that will be identified in that root cause analysis, and will hopefully then provide a new path towards recertification in terms of what are the new milestones or corrective actions that need to take place that have not already been implemented. So we will be keeping both the Joint Conference Committee and the Full Health Commission apprised of both the RCA and the action plan, and we'll be reporting on it here at the JCC and at the Full Health Commission. Next slide. You will recall that back in end of June and July, we conducted our mock survey number 1. Remember that we utilized the other consultant group, Health Management Associates, to essentially emulate the actual CMS certification survey. They came in, did a top to bottom CMS survey process and identified 101 different areas in CMS rules where Laguna could not document that we met full compliance. And remember, this is something we actually asked for. We sought out a consultant who could come in and give us an unbiased, fair assessment of where Laguna Honda stood in relation to the CMS standards, so that we would be better positioned to know where our deficiencies were and develop countermeasures to come back into compliance. This chart shows our current status through November 4th. The darker bar represents all 101 tags or findings that HMA identified in the mock survey. You'll see that all of those bars at 100%, which means we have fully implemented the corrective action plans for those findings. The second bar, the yellow bar in the middle, represents the step 2 in the mock survey correction process. And that is, each of those findings had corrective actions developed, and we are requiring that all those corrective actions have to go through a monitoring process where we receive and analyze data in order to support and establish that the approved plan of correction for that particular item actually has been made and appears to be able to be maintained. And then finally, the last bar, the green bar, the shorter bar, represents then the third and final phase of mock survey correction. That represents, of those 101 findings, which of them have gone through the first 2 processes and the third and final one, which is validation. So after the plan was implemented, it went through at least a 2-week monitoring process. And you should know, for some of them, when we actually tried to verify that monitoring process for 2 weeks, we found that we had to send it back to the process owners because they didn't provide enough documentation to substantiate the monitoring. And so this was not a rubber stamp process. This was a very thorough review process because we didn't want to have any mistakes. And you will see that in terms of that last bar, we are at now 41% of those 101 findings have now gone through the complete process of implementation, monitoring, and then validation that the change was made and is sticking so that we can maintain ongoing compliance. Next slide. And in the next few slides, we want to share with you some of the actual data from the many different processes we are using in order to determine whether or not we are on track towards making improvements towards recertification. You will recall that April 2022 survey that was done that led to the decertification, there were several findings related to the areas of infection prevention and control, particularly related to hand hygiene, appropriate use of personal protective equipment, PPE, and the overall environment of care of our neighborhoods or our nursing units. So this slide represents the environment of care. You know, is the nursing unit kept in an orderly, clean, organized fashion? Are resident call lights responded to in a timely fashion? Are medication carts stored in the appropriate places and locked appropriately? For all of our measures in these areas, our consultants gave us a target of at least 90% as the goal for compliance. And you can see for the last several weeks in the area of environment of care, we've been over 90%, closer to 100%. Next slide. Similarly, in the area of hand hygiene, again, one of those things noted in that last survey that led to decertification, Again, the goal, the target goal for compliance is 90%. And you can see for the last several weeks and a couple of months, we've been at or near 100%. And next slide. And then finally, in the area of overall infection prevention and control. So this is a little more comprehensive. You know, each of our neighborhoods has its own galley kitchen. So one of the things we look at is, for the food that's being stored in those kitchens, are they being stored appropriately? Are they being labeled with the date that they were put in and by which they need to be discarded? You know, are the staff routinely using PPE appropriately? Again, the threshold was 90%, and for the last several weeks, we have been over that threshold. Next slide. So we wanted to take an opportunity to share with the joint conference just some of the accomplishments that have occurred. And there are numerous ones, but we tried to pick out a few that stood out because it really represents all of the hard work that the staff have been doing for the last 6 months. And I must say, you know, we have been working at a level of intensity that I think none of us have seen before, but that is what's required in order for us to make sure we are on the path to recertification. So one of the accomplishments has been that we have utilized some of our lean process improvement training, where we have chartered 5 performance improvement processes, particularly related to the findings in the mock survey and our ongoing observations where we continue to have problems with compliance. These teams include frontline staff and management, where they come together, look at a problem, and creatively develop solutions and countermeasures. They've looked at areas such as care planning. Do our residents have individualized plans of care, which are core to meeting CMS SNF requirements? Are we appropriately using physical restraints, and not only using them, are we appropriately documenting the efficacy of that use? We instituted a performance improvement project on tube feeding, and similarly the same on call lights. I will call out the call lights issue. In fact, I recently did rounds on some of the neighborhoods at Laguna. And as I talked to staff, I explained to them that we are about to begin a pilot very similar to this, where we will be piloting utilizing staff beyond just the nursing staff assigned to that unit, but other Laguna staff who come onto the unit on a regular basis. So for example, our dietary, food and nutrition staff who come up every day to deliver and remove trays. Our facilities folks who come into the units to fix and monitor the physical environment. And our EVS, environmental services, the folks who come in and do the cleaning and maintenance. So our care experience team led by Jen Carton-Wade will be working with other leaders to actually look at how can we expand the number of people who respond to a call light. I'll give you a personal example. I was rounding on units about 3 weeks ago, and I saw a call light that was on. So I looked around, I didn't see a staff person, so I went into the residence room and introduced myself and said, "Hey, I see that your light is on. Is there something I can help you with?" And the resident said, "Well, yes, I'm a little cold. Can you tell me, is there a window open in my room?" And I looked around and said, "Yes, there's a window right here that's open." And he said, "Well, would you mind closing it for me?" And I said, "Not at all." So I closed the window, and the resident said, "Thank you so much." So I then went to the nurse's station and informed the staff, "Hey, I've already taken care of that call light. We can turn that off now." And that's the process we're going to be piloting on other units. You know, we should not only be relying upon the staff assigned on that nursing unit. When others of us are there, we should be able to respond to residents, and if so, help support our team members to make sure that those lights are answered in a timely manner. So that's something else we are implementing. Next slide. Other accomplishments, one of the things we determined early on after decertification was that for whatever reason, Laguna Honda had never joined the California Association of Healthcare Facilities, CAF. CAF is a statewide association of all skilled nursing facilities in California and other long-term care organizations. So it is basically like if you think of acute care hospitals, CHA, California Hospital Association, this is the equivalent for skilled nursing facilities. So we have been a member of CAF for about 3 or 4 months now, and we were lucky enough to have 6 of our Laguna Honda staff members who submitted and have been accepted into the very prestigious CAF Leadership Academy. And this is where staff from skilled nursing facilities go through a year-long fellowship program to learn about best practices and process improvement within skilled nursing facilities. So we're so proud of our 6 staff who have been accepted and look forward to them participating and bringing their learnings back to Laguna so that we can spread it throughout the organization. Other examples include that we, working through our consultants, have also done major overhauls in both our infection control program and its structure. We changed the reporting from where they previously reported to quality management. They now report up through nursing operations. And our consultants have also helped us to make enhancements in our overall QAPI, our Quality Assurance Performance Improvement Program. And hopefully you will begin to see some of the results of those improvements as we begin to report out on the quality side to the joint conference. Next slide. So as you can imagine, being a skilled nursing facility, the nursing department is the largest department within the organization and has been a significant focus of all of our improvement efforts. And you've heard before from our interim chief nursing officer, Terry D'Antoni, but she has done a great job, number one, taking the advice of our consultants and restructuring the nursing organization at Laguna Honda that she previously presented, and also instituting improvement efforts like the use of unit-based huddle boards on each of the 13 neighborhoods. Terry also hosted the very first ever nursing town hall for the Laguna Honda nursing staff a week ago. So again, so that nursing leadership and nursing frontline staff could all be on the same page and working together towards recertification. She's also working with experts to review and establish an acuity system in order to better inform the appropriate staffing of the units at Laguna. Next slide. And I mentioned that Terry worked with the consultants to restructure the organization of nursing services. And this structure that you see here represents the best practice that our consultants brought to us in terms of best practice skilled nursing facility structure, where you have a director of nursing who is really responsible for significant geographic couplings of programs. So we went from just having one chief nurse and different directors to having a chief nurse that Terry occupies that position currently, but now we have 2 directors of nursing, one for each of the patient care towers. And this is meant to emulate, think of it as if these were 2 different skilled nursing facilities, each with its own director of nursing. So this structure provides a greater level of accountability. Rather than having several nursing directors responsible for all of the units, it now allows for greater accountability in one lead nursing director, so that we are able to ensure that There's no confusion as to who is responsible for the organization of nursing services in either of the two resident towers. Next slide. We've talked before about preparing for the new phase 3 CMS requirements regarding skilled nursing facilities. We actually, last Friday, November 4th, leaders from Laguna Honda had an hour-and-a-half meeting with CMS and the California Department of Public Health solely on the issue of these new phase 3 requirements. CMS and CDPH were able to walk us through each of those requirements and entertained our questions and comments about how Laguna will ensure that it meets these new phase 3 requirements. We learned some good information, and we'll be using that to inform our scheduling a more in-depth review of phase 3 requirements with the joint conference. And so we wanted to have this meeting with CMS in order to help us then come back to you at a soon-to-be date with a more formal presentation on phase 3 CMS requirements. Next slide. So very early on in our recertification process, we recognized, given all of the intense work we were doing on process improvement, we also need to make sure that we were effectively engaging our staff, both not only in the process improvement, but also engaging our staff to find out, how were they feeling about this rapid pace of improvement and this rapid pace of change at Laguna. So we quickly established an organizational change management initiative. That change management initiative is led at the executive level by our Chief Experience Officer and Administrative Director, Jennifer Carton-Wade, who's on this call. And we now have a formal change management initiative that has a project manager and a lead. And they work with staff at every level throughout the organization, from myself and other members of the exec staff down to our frontline staff, where we really look at what is the human component of the experiences that we are all undergoing related to recertification. And we are using this as a vehicle to make sure that we are not forgetting about the needs of our staff, making sure that we are celebrating successes, and also listening and hearing areas of concern so that we might address them proactively and timely so that they don't present a barrier towards recertification. Next slide. Just also wanted to reiterate the issue of the triplet rooms. You'll recall that when the new Laguna Honda opened in 2010, it met the then CMS rules related to a number of patients who may share a room and a single bathroom. And at that time, you could have up to 3 individuals. In 2016, CMS changed its rules to saying you can only have 2 individuals in a room that share a bathroom. Due to that decertification process, we've been told by CMS that we should expect to be held to the new rules, to the new standards of no more than 2 rooms that share a bathroom. So what that means for Laguna is that we have 120 beds who are in that 3-room configuration. And we are continuing to advocate for the ability to keep those beds in use. However, we have made sure that we are at least meeting the current requirements. And currently, we have been able, because we've not had new admissions since January, and we had those transfers and discharges, we were able to reconfigure the current Laguna resident population to meet the current standards. So we are currently meeting the requirement of no more than 2 residents sharing 1 bathroom. Because this issue of these 120 beds is very important, not only to Laguna, but also to the overall skilled nursing facility bed supply in San Francisco. We have elected to keep those beds on our license as we continue to have dialogue and pursue advocacy with CMS, so that hopefully whenever they do come out to survey for recertification, that they will include those 120 beds in the beds that they certify Laguna for when it comes to being reestablished in the CMS program. So what that means is we have kept those beds on our license. You know, we are licensed for our full complement. We just got our new license last week. We continue to have all of those beds licensed for our full complement of 780. But the unknown that remains is what will CMS actually certify when they come out for that survey. So as we learn more, we will keep the Joint Conference Committee and the full Health Commission updated on this issue. Next slide. And obviously, you know, COVID continues to be an issue that we are watching closely. We stood up our COVID-19 incident command at Laguna, and it continues to be active because we know we have to be nimble in our responses. You recall back in August, we had a surge where we had up to 55 residents who were COVID positive. Next slide. And you can see that based upon the data through November 2nd, we had 0 residents who were COVID positive and 4 staff who were COVID positive. So we are continuing to monitor our COVID status very closely to make sure that if we need to make any changes in our COVID protocols, we do that as expeditiously as possible. Next slide. And this is a slide that we have been providing at Laguna for many, many years. And this just shows the total number of admissions, discharges, and expirations. And as you can imagine, we've not had new admissions since January of this year. We had those 57 transfers and discharges and have had 113 expirations through October of this year. Next slide. And so that concludes my overview. And again, we've got members of the exec staff who are here and happy to try and answer any questions you have for us regarding this leadership report. Thank you.
Okay, thank you, Mr. Pickens. Can Mark, if we see if there are any public comments?
I don't see hands yet, but folks on the line, we're on item 4, the executive team report. If you'd like to make comment on this item, please press *3. And again, all comments should be related to this item and material that was reviewed as part of the item. Great, I see 3 hands. Each of you will have 3 minutes. I'll take you in the order that you are listed on the screen. Person on the line, you're unmuted. Please let us know that you're there.
Hello, this is Donna DiFemia. Can you hear me?
Yes, please begin.
Yes, thank you. Hi. I've been on some of these before, and my brother is a patient still at Laguna Honda Hospital and was not transferred out and was not one of the 57 that got transferred and of the 9 that passed away tragically. I've been visiting him regularly, and you know, every time I go to Laguna Honda, I just feel that, you know, things are just getting better and better. And for that end of things, it's just, you know, great in so many levels. But you know, the way that the CMS is doling out these, you know, 1 year or 3 months, you know, it's like we can celebrate, yeah, we can stay open longer, but it's still nerve-wracking. It's still terrifying. And if you look at the larger picture of what's going on in the whole country, you know, today there's a Supreme Court, you know, case being heard in Indiana, you know, nursing home. And it's terrible. I mean, what happens in February 2023 if there's no compliance, passing recertification, it's hard. It's still horrible for a family member to have to be sort of, holding on by your fingernails, wondering, oh, is it going to pass now? Okay, we have 3 months. We can take a breath. Okay, in 3 months, maybe we can have 3 months more. It's really exhausting. And I'm just hoping that there can be some kind of bigger change in the way things are in general for skilled nursing facilities. I mean, honestly, how many of us have said, what happens if Laguna Honda closes? What happens to the staff? What happens to the patients? With an empty hospital, it's outrageous to even think about still. So I just want to say thank you to Laguna Honda and everyone that's been doing a great job. And then I just want to say we have to still do something about this horrible situation and include those beds of 120. For one thing, there's just no place for people to go. It's a horrible trajectory. Thank you.
Thank you for your comments. Caller, you're unmuted. Please let us know that you're there.
I am at Patrick Minutsaw. The settlement agreement you and the Board of Supervisors reached still stinks. Plus, the quote-unquote new closure plan, end quote, has not been released to the public. This JCC should release it immediately to the public for the purposes of full transparency. Regarding Mr. Pickens' slide number 6, only 10 of the 13 patient units are in compliance as of October 21st with the infection control and prevention metric. That's 80%, not 90%, as Mr. Pickens stated, since the tracking began on August 6th. Why is it taking so long to get those 10 units plus the other 3 units up to 90% plus compliance? Slide 12 said that 6 Laguna Honda staff joined the California Associates of Healthcare Facilities for a quote-unquote leadership academy, end quote, to strengthen knowledge of SNF regulations instead of hiring a nursing home administrator and an assistant nursing home administrator for SNF, who know SNF regulations. And this JCC should make hiring the nursing home administrator positions a priority. Get those people hired ASAP. Finally, Dr. Kerr's article noted that the nursing home administrators that have not been hired affect a dearth of knowledge. And currently, a consultant on the HSAG contract is filling the nursing home administrator and assistant nursing home administrator positions. You need to, quote unquote, SH blank blank expletive, or get off the pot and get those 2 positions.
Your time is up, Mr. Minutsaw. Thank you for your
hired.
All right, we got 2 more hands that I see. Caller, you're unmuted. Please let us know that you're there.
Hi, this is Dr. Teresa Palmer. I really appreciate Roland Pickens' effort to although it's somewhat repetitive, to explain what is being done at Laguna Honda. But as a longtime nursing home doctor, a lot of this is basic stuff that all staff knows that a call bell should be answered, and all staff should know how to wash their hands. I mean, why is this now a problem? And I think one of the root causes, which I guess you haven't found yet, because he talks about looking for it every JCC meeting, is lack of management trained in nursing home regulations and operation in both nursing administration and Medi-Cal. And I notice your new chief medical officer has been pulled once again from San Francisco General with no history of nursing home experience. And I do hope you're hiring. The other thing I want to say is the people of San Francisco cannot afford to lose 120 Medi-Cal nursing home beds. And the next date to begin discharges is less than 3 months away. And how is that going to be extended? And when will we know that that will be extended? Because people will die if discharges start again. There's no place for these people to go. The third thing I'm worried about is that you are not disavowing the FLOW project, which allowed the entry of people with primary active substance use and primary unstabilized mental illness, which cannot be handled safely in a nursing home, and the admission of who violates not only Laguna Honda's admission regulations, but state and federal admission regulations. The only way to control an active substance abuser at a nursing home is to violate their rights per phase 3 rules. You cannot search patients. You cannot go through their personal belongings. You cannot tell them where to be and what to do in the way that someone who is using illegal substances needs to protect the others around them. So any way you have it, if you have a person in that situation at the nursing home, you are violating nursing home regulations. Can we please return admissions to the Laguna Honda staff and publicly say that we are not admitting untreated active substance users? If they're treated, if they're on methadone or buprenorphine or whatever they need to stabilize, and they have a primary need to be in a nursing home, that's a different story. But I don't hear this being stated. I don't hear any honesty or transparency around this. Thank you.
Dr. Palmer. I've got one more hand. Let's see. Caller, you're unmuted. Please let us know that you're there.
Yes, this is Michael Lyon from Grey Panthers. I've got to say there's an incredible disconnect between the huge amount of detail, almost mind-numbing detail, about the recertification and a complete absence of information about some very severe life and death kind of matters. What is being done about the revised closure plan? You must release that plan so we can know what's going on. Are you still planning to resume the deadly discharges if Laguna Honda makes unsatisfactory progress in recertification? Do you seriously think that it would be possible to safely do these discharges? I mean, I worry that you are thinking that since you have more time to be able to plan this, that you'd actually be able to do it and to actually try to do it. And more people will die when this happens. The other thing we don't know about is what is satisfactory progress in recertification as far as CMS goes. What kind of, how severe hoops, how high are the hoops going to be in order to be able to not resume these deadly discharges? How do we know that the FLOW project isn't being reinstated? sub rosa. Everything is being done in secret. It's just incredible that the Board of Supervisors and you should be talking about approving the settlement in closed session. We need to know what is going on there. We need to know what the revised closure plan is. You need to do this out in the open where we can be there with our knowledge and with our dedication to preventing people from dying. Thank you.
Thank you for your comments. Commissioners, that's the only public comment that I see. So it's to you with questions and comments if you have any.
Okay, are there any questions or comments from members of the committee or the commission?
Dr. Chow.
Dr. Chow.
Yes, thank you. I noted that today we received a notice of several changes on the executive staff. I wonder if Mr. Pickens can explain and how this strengthens our recertification and management expertise.
Yeah. Thank you for that question, Dr. Chow. So you're referring to the fact that, part of the restructuring towards a best practice skilled nursing organization includes moving towards assessing the nursing home administrator and or assistant nursing home administrator role. So as we've previously shared, in order to move forward with that, we are utilizing consultants in those roles currently, and then they are working side by side with the current Laguna Honda leadership, namely the nursing home administrator through the consultant group works directly with myself as the CEO, with the chief nursing officer, and with two administrative directors, Jennifer Carton Wade and Chauncey Jackson. So the way we are piloting the nursing home administrator role is that Jennifer and Chauncey as administrative directors that is our attempt to have the current nursing home administrator basically teach them and us how to incorporate that role. So Chauncey you can think of that role that he and Jennifer occupy as our trial run on the nursing home administrator role. Chauncey has accepted a new position at Zuckerberg San Francisco General and will be moving over there. And so the change that you heard about today is acknowledging Chauncey's promotional opportunity that he accepted there, and the fact that we are still staying vigilant towards bringing in this nursing home administrator model by backfilling Chauncey's administrative director role, which again is akin to the nursing home administrator. And so that's the notifications you received. Hope that answers your question.
If I could ask a follow-up question then on the nursing organization charts, and maybe while the print is a little small, you're saying that we're having a director of nurses for each of the two towers, which we understood in the past, and that certainly seemed to be helpful. But as I look at the little blocks, it looks like, and I'm probably not reading it correctly, but are there equal numbers of I guess you call them the living units that are under each one, or is it that one of the towers has more and one of the towers has less, and therefore we staff accordingly, even though we have a manager over it?
So I'll ask Terry D'Antoni to answer that question.
Great, thanks, Roland. Happy to take this on. So just to reorient, so we do have a director of nursing on Tower, North Tower and South Tower. On the South Tower, we have two nursing directors, one of which, Crystal Filietti, has 2 units, South 2 and 3, because she also oversees the Department of Education and Training with the clinical educators and the CNSs. So that makes her assignment whole in that regard. Ed Gina has South 4, 5, and 6, and he will be taking on, I don't know if that's updated, PMA, the acute unit as well. It sits over there, and it's a very doable assignment. In the North Tower, we have Marvin McGregor, and we have a vacancy. It was, we are in the process of hiring, and we have an acting, Soraya is acting right now, and they will split up the units in the North Tower. So it is equitable. They each have managers. And with the DONs, for example, today we had five surveyors in the building. Rowena was the DON in the North Tower. She had a director out and she sat with the managers and the CDPH. So there's a lot of depth and a lot of coaching and working within the departments to get the work done.
Thank you. That's very helpful. And I'm glad to hear that we have that much oversight onto smaller units than just suddenly, you know, an entire tower, so that there is plenty of help for the frontline staff. Sounds very good. My last question is actually if Mr. Pickens can explain the validation process. What period of time are we using to determine the validation process? And then how are we making sure that there isn't a lapse? I mean, if you take, you know, 2 cycles or taking 2 months, and then how do we know that it doesn't, you know, lapse back into non-compliance?
Right. Thank you for that question. I'm so glad you asked it. I will try to answer it, and Naz will clean it up if I don't answer it correctly. So the validation stage, which is the last one, occurs as I mentioned before, after there's been at least 2 weeks of monitoring. So we call a triad, a team of 3 that includes our consultant experts who then review that monitoring data to independently validate that the monitoring was done correctly and that the correction has stuck. And the way we ensure that this continues and doesn't fall backwards is that each of those, then once it passes the plan of correction validation, gets referred on to our regular PIPS process, the Performance Improvement Safety Committee. So if there's a handoff from plan of correction to performance improvement in patient safety, and you received as a joint conference those reports that Naz gives. So each of those 101 findings, as they're signed off on the plan of correction, they are now migrating into the PIPS process. So you'll continue to hear about them, and we'll continue to monitor them so that they don't fall off the radar.
Okay, thank you very much. That's very reassuring.
Okay, thank you, Commissioner Chow. Commissioner Green?
Yes, well, first, thank you for the presentation, and it's great to hear about the progress. I want to make sure I understand something that you discussed. It seems like on the ground now you have all the expertise you need, and that the nursing home stipulations, whether it's phase 3 or the critical element pathways, are very well understood by our consultants. And now, when it comes to implementation for the staff, you really do have people with who are permanent at Laguna Honda, who are really the implementers, and that the roadmap and the notes you need to hit are clearly defined. They're very transparent at this point from CMS. In fact, there are so many that that there's an embarrassment of riches here. But you clearly have the expertise. So with that in mind, it would seem to me that ultimately we need senior leadership, but that you certainly have all the elements to both implement and sustain. And I wondered if I've heard that right. And in that context as well, you know, on one of your slides, you talked about the QAPI programs and that they've been revised to align with the newly updated CMS regulations. Are you how far along the line in really getting those programs set are you at this point? Because like you were saying earlier about how things go to PIPS if they do backslide that you know, you feel like the structure you put in place is really adequate and that you've accomplished that portion satisfactorily.
Right. Thank you for that question, Commissioner Green. So in terms of the redesign of the QAPI program, I would say we are still in the initial stages. We're still being informed and advised by the consultants. Nas can give more details, but one example is, you know, the one I just gave to Dr. Chow, where we're taking the plan of correction deficiencies and then folding that into the performance improvements, into the QAPI program. And that's something that the consultants advise us to do. Because I think in the past, you know, when the organization hasn't always made sure that improvements made in one area actually get folded into the formal QAPI review process. And so that's an example of where the consultant said, hey, make sure you're using the work you're doing on the plan of correction side to inform your overall QAPI program. And I'll ask Nas to probably fill in the parts that I wasn't able to answer in your question.
Sure, no problem. Thank you for the question, Commissioner Green, and good afternoon, everybody. So in regards to the QAPI program, there's been a lot of work with myself and the HSAG colleagues for the past few months reviewing our QAPI plan. And the specific focus is to ensure that we are calling out the work for the SNF. So as you all know, part of what we have done over the past year is try to streamline our PIPS process to ensure we're thinking about our residents as a whole as they flow through our SNF and our acute. And so a little bit of what we're doing almost feels like reversing that work, which is okay. It's making sure that we are really intentionally calling out the SNF regulations and the SNF work that we are already doing in our QAPI program. And with that, some of the work that we need to do is develop SNF-specific committees. So again, the work is happening, but we want to be really intentional that we're calling out it's related to our SNF. And so we've revised and it's gone to our PIPS committee a new QAPI plan that is in line with the phase 3 regulations. You know, and to Roland's comment of in the initial phases, now part of that work is operationalizing that new plan. So one of the components of that is developing what is called a QAA committee. So, you know, a quality assurance committee, and that will be really SNF focused and it will report up to PIPS. And so now I'm working on operationalizing those components. And I will, of course, bring it to you all as part of kind of the structure we talked about to ensuring you know the expectations of the overall PIPS program. And the QAA will now be part of that.
Thank you. Do you have any sense for timing, especially in the context of this revisitation? That's, you know, we have the long-term deadline and then the shorter one where we're talking about potential transfers. I know there's some benchmarks that are expected perhaps, and I'm wondering, you know, what you see as a reasonable timeline, because it sounds like the expertise is there, but what you're talking about is the structure to ensure that it's operationalized and the manpower, the people you already have that can guarantee that happens in this very large institution. So what do you think in terms of the timing of this and especially some of the structural things that you've discussed in terms of things we know we had to, benchmarks we know we have to meet?
Yeah, so I can start. So for me, probably the most urgent timeline is the submission of the root cause analysis by the QIE to CMS. So the work is going on, as Nas said, and has been going on for several months. But under the terms of this settlement agreement, the QIE must submit the RCA and have CMS approve it. So, and that RCA, I believe, is due the first week of December. And so we want CMS to approve before we make any, you know, definitive long-term plans. We want to make sure CMS approves those plans we want to do in the QAPI program that Nas talked about. And so that will all be in the RCA. And I think once we then have CMS approval on that, then we can begin to move more quickly. But again, the work is happening, but we want to make sure it's officially sanctioned and approved by CMS before we codify it in a more final process.
Well, thank you so much for that clarification. That makes a tremendous amount of sense. And so December 1 is sort of your first benchmark then, timeline.
Yes, I think it's like December 6th or 9th. I don't have it, but it's spelled out in the settlement agreement when the date that the QIE must submit that RCA to CMS.
Wonderful. All right. Thank you. Thank you very much.
Thank you, and thanks to my fellow commissioners for the insightful questions on this. I just wanted to make one observation or comment. The fact that you just joined the California Association of Healthcare Facilities, I think, is an indication of how I guess what had appeared to be sort of a basic I guess, assumption by members of the commission, the public, and everybody else concerned about Laguna Honda around the infrastructure and organization of Laguna Honda as a SNF versus an acute care facility really does sort of come to light, even in this sort of seemingly mundane membership of something that would appear is going to provide a tremendous amount of information and validation and I guess support for what we are trying to do in response to not just the recertification need, but the sort of future strategy, the future infrastructure for Laguna Honda, just acknowledging all of the different challenges and changes, I think that need to be incorporated as we as we move into the future. So I look forward to hearing, hopefully in a future report, what these folks that have been accepted into the leadership piece of this are learning and how that's being integrated into what is changing at Laguna Honda. And so I'm hoping that we'll be able to hear that from you as things progress.
Absolutely, we will definitely keep you informed. And I can tell you that membership has already paid off in dividends. CAF has actually dispatched several of their team, their leadership to Laguna. They've been on site, have been consulting with us and giving us advice and counsel. And so that membership has already proven to be substantially beneficial.
That's good to hear. Okay, so why don't we go ahead, Mark, and move on then?
Great. Thank you, Mr. Pickens. We can move on to item 5, the hiring and vacancy report. Ms. Johnson.
Hello, commissioners. I'm happy to be reporting back, this time with the summary for Laguna Honda Hospital. The vacancy rate increased last month to 10.1% from 9.2% in September. And on the RN, vacancy rate is at 3.7%. We did hire 38 employees in October, and we had 0 separations. I do want to share some recruitment and hiring challenges. The first issue that we've had at Laguna is higher than normal requests to reassign out to other locations. As an example, since May, we've had 18 RNs reassigned, with 7 in October. That has an impact on the operation. To help mitigate this, for last month, we have 2 P103s and 2 2320 RNs targeted to start this month. We're also having some difficulty in filling vacancies with low interest in our positions. We're doing what we can to work with managers to make selections faster through application review process. Also, direct hiring did end per the mayor's declaration that was on June 30th, 2022. Thus, nurses and other classifications that had been approved for direct hiring, we must revert back to going to an eligible list. This does increase the time to get candidates to managers, as we must go through the eligible list process through merit. I want to highlight some successes. The first one is partnering with our Department of Human Resource ACE coordinator. ACE is the Access to City Employment, and that's to fill some of our entry-level positions. The ACE program is an alternate route to hire, which bypasses some civil service rules around eligible list and selection, allowing for disabled individuals to be selected for city jobs. We hired 7 patient care assistants via the ACE program last month. We have 2 more applications under review targeted with start work dates in December. And for facilities, we did partner with our hiring managers to fill 10 positions in CAT 18 exempt appointments for the research efforts. 8 started in October or this month in November, with the remaining 2 targeted for December. For new hires, just an update of where we're at with our orientations. On 10/31, we had 15 new hires on there, and for the 11-14 class just coming up, we have 18 for new employee orientation. Are there any questions?
Let's see if there's any public comment on this item.
Folks on the line, we're on item 5, the hiring and vacancy report. If you'd like to make comment, please press *3. I see one hand. Hi, caller, please let us know that you're there.
I am. It's Pat, your favorite member of the public, Patrick Monette Shaw. I know you people love me, right?
You've got 3
So, are you hearing me?
Yes, loud and clear.
Okay, so since it's understood that you love me, let me repeat, I will be submitting 150-word testimony to Mr. Morowitz on this item and the previous 2 items, item 3, public comment, item 4, executive team report. Because I'm still in a skilled nursing facility myself, Mr. Morowitz, you may not get that written testimony, until Sunday afternoon, but that should still be plenty of time before you have to pull together the draft minutes of today's meeting. It's as far as item 5, vacancy report goes, I do have some observations I'll make in written public comment, but again, I want to be a bit redundant here in saying that you should be, on a vacancy report basis, you should be reporting on the status of hiring the replacement for the nursing administrator, Mr. whatever his name is, who's a counterpart of Jennifer Carton Wade. Why didn't we hear anything about the status of hiring for his position? And as I've repeatedly testified, we have not heard one word about Laguna Honda starting to advertise and recruit for those 2 nursing home administrator positions. Presumably, if HSAG's contract ends at the end of December and they take their 2 temporary consultants managing the 2 nursing home administrator upcoming positions, and they go away come January, you will have nobody filling those roles. You need to be recruiting and advertising now to get those 2 positions filled, and frankly, you haven't had those positions since Mr. Funk was left.
Thank you for your comments. That's the only public comment, commissioners.
Okay, thank you. Let's see if there are any comments or questions from the commission members on this. Dr. Chow, Commissioner Chow.
Yes, thank you. And thank you for the report. I'm just wondering, your summary is similar to what we use at General, and whether or not we can get a written summary so that we could actually see the same data, and that kind of helps reinforce it. I think the second question is, I'm wondering, and this is going back a number of years, Mr. Pickens will also be very acquainted with this. We thought that we were going to be shortening the HR process, and had been working with the city to actually make changes. This sounds like we're slipping back into where we were many months ago. So I'm wondering if we can get a report through HR in either of our joint conferences as to what is going to be the difference as versus where we were before the pandemic, which also was already moving the needle somewhat. But with the pandemic, the silver cloud there was that we actually could hire really good people really fast, right? And so I'm not sure, but I think it would be nice if we got to hear if we're going to return to a pre-pandemic period, and what is the length of that for normal hiring, and what are the I would say, what then were the reforms that we do or don't have anymore, and that we had understood that the city was actually looking at trying to streamline this process, because us being the biggest department trying to fill very critical issues, I think it really hurts us the most.
I can answer both of those, Dr. Chow, so it's nice to see you again. The first one, I do have a written report. I did submit it. It just didn't get added to the packet. I think it's new for Laguna, so, but I did prepare that report, so we can get that over to Mark to add it, but it was just not included. But I gave a summary of what was on there, but you will continue to get that on a monthly basis, so it gets just a summary of where we're at. And good timing on your comments to kind of where we may be going. Yesterday was the Civil Service Commission meeting, where we also talked to commissioners there about rule changes that we're proposing as the city. So Department of Human Resources, our city organization, presented a number of rule changes which are going to speed up hiring. They presented out public information that the average across all city departments is 255 days to hire. That's all city departments. And so, of course, the goal is to reduce that across the board by creating processes, not just at DPH, but everywhere, to reduce it. And we have a lot of great ideas coming through. It's going to have to be approved by the commissioners, right? Because these are rules that are changed. But we're talking about timelines and that were put in place 50 years ago, when maybe we were doing things by mail instead of posting online, where people can apply for a job on their phone versus going down to a job board, taking down the information and filling out an application. So we're really looking forward to reducing those timelines at the city level. And then on our side at DPH, what we're doing is continuing to work with managers to speed up the selection process, ways we can continue to do that. You are correct that by my reporting out that losing the ability to do direct hiring, which means hiring nurses without waiting for an eligible list, has greatly impacted our ability to fill our nursing positions. And what we're working with colleagues again across the city is, how do we do all continuous testing and kind of on-demand exams so we can get eligible list faster in the hands of our managers instead of the normal process. So it's a little hard. I can give a presentation, but nothing can be formalized because a lot of this are proposals that we need a lot of, we need the approval from civil service. But I'm happy to share a little bit more about that next month and in upcoming months as we continue to work on those really important and necessary changes.
Well, it's very much appreciated, and hopefully the city really will do something about the fact that it takes nearly 3/4 of a year before we can
Yes.
hire somebody. So,
Yes, because we know during the pandemic, we were able to hire some nurse specialties, not all, but some nurse specialties where we had large applicant pools in 40-ish days. So if we can do that, it can be done, but we just have to, we need help. Yeah, we need help with our processes and the ability to have the approval to do that. So I'm looking forward to those upcoming changes.
okay, well, I look forward to your updating, hopefully in a positive fashion. Thank you.
Sure.
Thank you for that question, Commissioner Chow. I think that's something that's on all of our minds as both the recertification and the restructuring of Laguna Honda is so urgent. Something like that could really sort of set us back tremendously. And so we support all of the efforts that you identify, Carrie, for moving quicker, and hopefully that'll happen. Okay, let's see the next item. I think Mark.
We can move on to item 6, the finance update.
Hello, commissioners. Can you hear me okay? Yeah, okay, great. Lily Conover, Laguna CFO. Good to see you again. So I have the finance report in your packets. It's the Q4 report, just the standard report that we usually include along with the Q4 gift fund report, which I presented to you last week at the full commission. So I don't think I'll go into much detail on the gift fund, but you're welcome to ask questions if you have any. And then I'll go through a few points on the Q4 report. I know that Jenny Louie presented the DPH-wide report last week, so there probably isn't too much to cover, but I'm just going to go into a little bit more detail on some of the variances on the report. And then if you have any questions, I'm happy to answer them. So I'm just going to start off with the revenue on the Q4 financial report. And just starting from the top on the variances, the Medi-Cal revenue, we had a 10.9% variance over budget, and that was just due to an increase in per patient funding related to the COVID emergency. And there's also an offset to losses from the DP-NIF funding to cover the reduction in our census. So that's what that variance is from. On Medicare, there was a deficit 4.54 under the 9.52 revised budget, and that was just decreased revenue due to lower census from COVID and admissions. The prior year settlements line item, that's just kind of a standard line item that we have every year. It's settlements that were reconciled from the previous year, so settlements from fiscal 21 that carried forward into fiscal 22. And then other patient revenue, we saw a decrease there, just a reduce in census of patients that we receive other revenue from that are outside of Medicare Medi-Cal. So reduced census year over year in that category, and that's driving that decrease. And in the other state miscellaneous, going down to line 17, that one is just an adjustment for the provider relief fund, the COVID relief funds. And it's an adjustment from the prior 2 fiscal years. We thought we could claim more than we got funding for, so there was a one-time adjustment to reconcile that. On the expenses side, there isn't much there. There's a small salary and fringe variance due to some of the vacancy, turnover, and hiring items that Carrie was referring to in the last report, and then minimal variances in materials and supplies and work order billing. So not too much to report on the expense side. And then the gift fund report, as I mentioned, I think I went over that in pretty detail, in good detail last week. So I'll just open it to any questions you may have on either of the reports.
Thank you. Thank you, Lily. And now, Mark, if we can see if there are any public comments.
Sure, folks, we're on item 6. If you'd like to make comment, please press *3. Again, item 6, the finance update. I do not see hands.
Okay, thank you. Are there any questions or comments from members of the commission? I don't see any hands up. Okay, You got off pretty easy, Lily, on this one. Thank you.
Thank you.
Let's continue on.
Sure. Item 7 is the Regulatory Affairs Report.
Hi, good evening, Commissioners. This is Geraldine Mariano, Director of Regulatory Affairs, and I'll be sharing the Regulatory Affairs Report for Laguna Honda for the month of October. Laguna Honda reported 22 facility reported incident to CDPH for October, and we received at least 3 anonymous complaints. There were a total of 5 unannounced site visits from CDPH. And also, these are mostly follow-up from facility reported investigations and anonymous complaints. Please let me know if there's any questions or comments that I can address at this time. Thank you.
Thank you, Geraldine. Let's see, Mark, if there are any public comments?
Sure. Folks, we're on item 7, the Regulatory Affairs Report. Please let us know if you'd like to make comment by pressing *3. I am giving it just a second, and I don't see any hands.
Okay, thank you. Any comments or questions from members of the commission? I don't see any hands up. Okay. Thank you very much. We'll continue on.
Sure. Item 8 is a presentation, the Performance Improvement Patient Safety Committee Annual Review.
Thanks, Mark. Lucia, would you mind pulling up the presentation, please?
Just give me 1 minute.
Thank you.
Can you see?
It's not showing up. Okay, there we go. It's up.
That's the Regulatory Affairs Report.
Sorry, it's a PowerPoint?
Yes. While Lucia does, I'll just go ahead and at least start with the introduction. So good evening as the sun has set. I'm going to share with you our annual fiscal report for fiscal year 21-22. Thank you so much, Lucia. A review of our PIPS committee. This presentation has gone to our PIPS committee, and of course want to bring it here to you all. And we will go ahead, if you will advance to the next slide, please, Lucia. During the presentation, I will go ahead and cover our True North metrics that we continue to monitor here at Laguna Honda Hospital, do an overview just of, how is our committee doing in terms of attendance, how many policies are we reviewing each month, and then of course we always monitor our census within the facility, and highlight of a few of the FTAGs that we were monitoring over the past fiscal year and other reports. Next slide, please. For our True North metrics, so for our workforce, which is the increased likelihood to recommend, our goal was not met. Our goal was to achieve 85% of our staff would be likely to recommend Laguna Honda, and we attained 77% of our staff expressed that they are likely to recommend to work at Laguna Honda. For financial stewardship, the True North metric was to not exceed our general fund or our general growth. And so for the last fiscal year, we were able to do that with less than 2.4% spending of our general growth. For equity, the metric is to reduce the number of discrete incidences per category for our Black African American patient population. This metric is reviewed through a number of incident reports through our UO system, and the goal was not met. For fiscal year, we had 492 incidents. Part of this has to do with clinical safety searches and interactions with law enforcement on campus. Next slide, please. Thank you. For our safety, reduce resident harm events, this goal was met. The goal was to achieve 68 events or less, and the actual was 58. For safety, again, increased medication reconciliation, just shy of the goal. The goal was 95, and the facility achieved 94%. For our care experience, our item is to increase likelihood to recommend care, again, just shy of our goal of 100% with the actual of 99%. These True North metrics will continue to be monitored through the fiscal year 22-23 or until the facility deems new True North metrics through any strategic discussion or planning. But of course, with a focus on certification, that likely will not occur until we are successful in our certification efforts. Next slide, please. So for our PIPS committee, as you all know, we do meet monthly, and we have several members who are considered our committee members and also guests. Often guests are those who are presenting their reports who are not part of the official committee. You can see the breakdown of attendance month by month. We did not meet in the month of July for fiscal year 21-22 as we were doing some strategic planning and rethinking of how our PIPS committee would look throughout the upcoming fiscal year. And we often do not meet in the month of December as it falls close within the holidays. However, this year, because of the many items that we need to track, we will be meeting in December this year. We had an average of 67% attendance month over month, and that's accounting for excused absences. My goal is to improve this over this fiscal year, as well as have a far more robust and interactive committee throughout our meeting time together. Next slide, please. This shows the number of policies that the committee reviewed each month. You can see that the majority are at August of 2021 and June of 2022. Part of this is because of the annual process that we do for policies that is required for skilled nursing facilities. We must review all policies annually. However, we are doing a process improvement this year to level load a little bit and not bombard staff in just a short month time frame, which also happened to coincide with PPAR season. So we are now doing a monthly intentional review. So you'll see hopefully that this is more even as we review the fiscal year for 22-23. Next slide, please. Here's our breakdown of our average daily census. The blue line shows our acute, which our goal is to stay above 2, which was achieved. And then the orange line is our SNF, as you see the gradual decline as we approach the end of the fiscal year. Next slide, please. I will go over, these are the FTAGs that I will review monitoring reports for and share with you if the goal was met over the fiscal year. Next slide, please. For infection control, over the fiscal year, we reviewed hand hygiene during mealtime, tube feeding, cleanliness, ensuring that our syringes and oxygen tube feeding devices are labeled appropriately, and spot checking of resident rooms and bathrooms for cleanliness. The goal was to achieve 95%, and the goal was met for each of these categories. Some of these items will not be reported independently to PIPS anymore. However, they are still monitored through the IPC rounding staff that rounds 24/7, 7 days a week. Next slide, please. For nursing monitoring, there are several tags that the nursing team reviewed throughout the fiscal year, with each having a goal of at least 95% compliance, and each of their F tags and areas monitored, the goal was met. Again, some of these items will not be called out specifically during PIPS as they met the threshold of 3-month compliance, but do continue to be part of their daily rounding. And we are trying to review all the QAs that nursing is doing to ensure that we are focusing on the most important and most necessary out of respect for their workload. Next slide, please. Some of the other monitoring reports that we did throughout the fiscal year were related to our substance use, environment of care rounds, clinical safety searches, urine toxicology screens, timely reporting of allegations of abuse, as well as the others you see on the screen here. Many of these will continue through this fiscal year. Next slide, please. For the monitoring report, so reducing the risk and harm from substance use, the goal was not met. This will continue in this fiscal year. Our environment of care rounds by our nurse managers, the goal was met. We will not continue to report this to PIPS, but the work does continue. Resident assessment after out on pass, goal was not met. And we are actually having a deep dive on this particular monitoring report to ensure that we are looking at the appropriate metric, if you will. So the facility policy is that the assessment must be done within 1 hour. So we are now generating an EPIC report to help us support nursing staff in ensuring this work is done timely. That will continue through PIPS. Next slide, please. For our urine toxicology screens, this goal was met. We are rethinking this report and the intent of this report. The QM team does continue to monitor daily any positive urine toxicology screens and ensure all appropriate follow-up and documentation is done. Timely reporting of allegations of abuse. The current window in practice is 2 hours. Just to note, in phase 3, there will be updates to this. There is a change in the reporting in that if there is no bodily harm or injury to the individual, the facility now has 24 hours. So we will begin educating on that to show we have more time. However, for this particular item, the goal was not met over the fiscal year. We do monitor this monthly within QM and share with PIPS. I am proud to say for the month of October, we were at 100% compliance, which is excellent. For payer eligibility, this was at 100% compliance. The goal was met. This item will not continue through PIPS. However, the team, which is the utilization management team, does continue to monitor this through their own work and report to their committee. And the care plan audits, the goal was met. And as you know, we continue to do care plan reviews and audits because there is much work to continue here, even though the goal was met for this particular audit of individualization. Next slide, please. For medication administration, for the 0 expired meds for the fiscal year, the goal was not met. However, most recently, there was a lot of work that this team had done and had success over the past 3 months. And after consultation with our experts in-house, this report will not be coming to PIPS anymore as they did meet their goal and threshold. However, the physician team, along with pharmacy, will continue to monitor this work. Med simplification will continue as the goal is not met, and a lot of discussion of how to support this work with our physician colleagues. Medication spot checks, goals were met. Drug diversion, goal met, and drug diversion prevention, the goal was not met for a 90% response to the DRR as it relates to psychotropics. The team has not met the 90% threshold. They still have some work to do there, and so that will continue. Next slide, please. So our next steps for our fiscal year that we are in now, we have our CEP reviews, as you know. We continue to do this, and QM continues to be involved heavily with this review, as well as staff across the facility, which is an excellent way to make sure we have interdisciplinary support of regulation review. Our performance improvement projects, or PIP plans, we are now starting to develop PIP plans or PIP charters for items where we see there needs to be a really big deep dive, such as care plans, pain assessments, call lights, restraints. There just needs to be essentially level setting, having intentional review, really assessing our process, not just looking at the data. So these are now being called out. We are rounding on units and solving problems in real time, as well as providing just-in-time education to our staff and ensuring that there is education and training, technical assistance for frontline staff, supervisors, and managers, not only by the QM team, but executive leadership and many other departments throughout the facility. And we continue with the RCA process. We have unit RCAs as well as organizational RCAs that are led by the risk management team, and bringing those recommendations and ensuring that we begin reporting and tracking these recommendations at the PIPS committee. With that, I open it to public comment and, of course, any of your questions or feedback.
Thank you very much, Naz. Mark, do we have any public comment?
Folks, we're on item 8. Please let us know if you'd like to make public comment by pressing *3. Again, *3. I see no hands, commissioners.
Okay, thank you. And so I'll turn to the commissioners. I see Dr. Chow has his hand up.
Right. I think this is a very nice summary on, and I'm trying to coordinate this with what you all had said in terms of which some of the key parameters from the survey report would then continue to go on to PIPs. But in some of these, uh, and so I guess the question is, if that is true, are any of these that you are going to be dropping, for example, zero expired meds? Uh, and I'm not sure that was a finding from the surveys, but if we're not going to continue to bring that to PIPs, which is what I think you said, uh, is that a one of the items that actually we had talked about that we would continue to monitor at PIPs?
That's a great question. So the zero expired meds did come from a abbreviated survey, not from the mock survey, that occurred last year during an incident that was reported to CDPH. And so this monitoring of the expired meds has been going on for roughly 14 months now. And so after, and in the first fiscal year, there was still work to be done. The intent of the review was shifted at the start of this fiscal year, so at July. And over the past 3 months, let me make sure I'm counting my months correctly. I apologize. After the 4 months, the past 4 months, and the team just came to PIPS in October and presented their information. The team did achieve their goal. They changed their review and strategy. And so after consultation with our consultant experts and the PIPS committee, the team was in agreement to stop the reporting to the PIPS committee. That being said, we still have EPIC reports. So anything that stops coming to PIPS does not mean that there isn't still monitoring. It's just the formal reporting to the committee.
Okay, so your comments that you made earlier are that those elements off of the mock survey will continue to be followed at PIPS.
Yes, very much so. So this item specific to the mock survey began coming to PIPS in August. So that's our new fiscal year, which is why it's not captured in this report. So
Sure.
those are still coming, yes.
Okay, no, thank you. Just wanted that clarification.
Yes.
Okay, I don't see any other hands up. So I guess we'll move on. And thank you, Naz, for that report.
The next item is the consideration for a closed session.
Okay. Do we have public comment on the consideration for a closed session?
Folks on the line, if you'd like to make comment on item 9, please press *3 now. I see no hands.
Okay, may I have a motion to consider a closed session?
I so move.
Second.
All right, I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Green,
Yes.
Commissioner Guillermo.
Yes.
All right, great. Members of the public, we will be in closed session. During that time, you will not be able to hear or see us, but we will be back into open session afterward, day for the adjournment. Everyone else, please give me a minute to take us over to the closed session. Thank you.
And thanks, members of the Laguna Honda staff that will be leaving us while we're in closed session and won't be coming back. Enjoy the evening.
Okay, we are in closed session, and give me 1 second to find. All right, commissioners and everyone, we're back into open session. Please, commissioners, consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
Second that.
I'll do a roll call vote. Commissioner Green,
Yes.
Commissioner Chow,
Yes.
and Commissioner Guillermo.
Sorry, yes.
Great. And now you're at a consideration for adjournment.
Okay, is there a motion to adjourn?
I would move adjournment.
Second.
Commissioner, I'll do a roll call vote. Commissioner Chow,
Yes.
Commissioner Green,
Yes.
Commissioner Guillermo.
Yes.
Thank you, everyone, and members of the
Thank
public.
you. Stay dry out there. It's cold and dry.